Okay, so fluid volume deficit. I think I left off somewhere around here. So this can occur alone or in combinations of other physiological imbalances. Sorry about my dog. There is the loss of extracellular fluid exceeds the intake ratio of water. So electrolytes will be lost in the same proportion that they exist in normal body fluid. Please remember that fluid volume deficit and dehydration are not the same thing. You can have a patient that is dehydrated that is not fluid volume deficit, or the opposite thereof. It really depends on the rationale. And some examples would be DKA, diabetic ketoacidosis, or HHNS. So those are two disease processes where the patient may have fluid volume deficit, but they are not dehydrated. It depends on the electrolyte imbalances. So in terms of fluid volume deficit, things I want you to be thinking about is how are you going to describe it? Skin turgor, mucous membranes, capillary fill. Those are areas in which you can describe the patient's hydration status. Causes of fluid volume deficit. So as I've already said, it could be diabetes, DKA, diabetes ketoacidosis. It could be adrenal insufficiency. It could be hemorrhage. Other causes could be vomiting, diarrhea, sweating, GI sectioning. Patients that have poor PO intake can also be at risk for fluid volume deficit, and they may have nausea or lack of access to fluids. And then lastly, third spacing. Patients that have ascites from cirrhosis, third spacing because of burns, may also have fluid volume deficits because of the shifts in their hemodynamic status and in the intravascular versus interstitial. Okay, let's talk about fluid volume excess. So this is the isotonic, remember all the different tonics, hypertonic, isotonic, expansion of the extracellular fluid caused by the abnormal retention of water and sodium in the same space. So this could be secondary to an increase of the total body serum content, so fluid volume excess, too much fluid on board. Types of patients that could have fluid volume excess would be renal patients, heart failure patients. Burn patients could also have, depending on the trajectory of their disease process, can also have fluid volume excess. But usually burns is going to be deficit because they lose, not gain. So causes, heart failure, kidney injury, cirrhosis, any overload or diminished homeostatic mechanisms in the body. It can also be contributed to consumption of excessive amounts of table salts or other sodium, such as in lithium. Lithium has an excessive amount of salts. So these patients can have fluid volume excess. Also, excessive administration of IV fluids that contain sodium. So that can be another cause of fluid volume excess. So how is your patient going to present? So what are we going to see? So we might see pulmonary congestion. The patient may be short of breath. Cardiovascular, you may see a bounding pulse. You may have hypertension. You may have jugular vein distension. You might hear a S3, which is a murmured, a third heart sound. The patient also may be tachycardic. From a GI standpoint, your patient may have nausea, and they may not want to eat, which is anorexia. They may demonstrate neurological changes in level of consciousness, confusion, headache. Depending on their sodium level, they may seize. And also you may see dependent and pitting edema in lower extremities. So those are things we're going to be looking for in these types of patients. So we talked a little bit about this, the signs and symptoms of fluid volume excess. So please refer to 13.4 for a complete list of signs and lab findings on these patients. but you may see edema. As we talked about, it could be anasarca, meaning generalized edema. You might see dependent edema in the lower extremities. You may hear adventitious lung sounds. I'm not going to teach you how to measure jugular vein distension, but you may read in the H&Ps that the patient presented with JVD. So those are things that we're going to be looking for in terms of clinical manifestations of fluid volume excess. How would we treat this? So you have a patient that's overloaded. What might we do for this patient? So let's take a look at this slide. So nursing management for this type of patient. So if we have adventitious lung sounds, we're going to be doing frequent respiratory assessments. We're going to be looking at his vitals. We're going to be looking at his oxygen saturation. We're going to be looking at the patient to see how he's perfusing. We're going to look for edema. Okay, we're going to look for a dependent edema, but we're going to look for edema anywhere in his body. If this is a renal or a heart failure patient, you might see orders for daily weights and fluid restrictions. Okay, we got to pay attention to that in terms of how much water we're giving the patient if they're on a fluid restriction with their medications. If they're getting NG or PEG tube feedings, we have to pay attention to how much free water they're getting. Or if we're giving NG medications, we need to pay attention to how much we're flushing in between each med. We have to really be looking. This is kind of like with this type of patient, you need to be the octopus like we talked about in week 1. You need to be really looking at everything, critically thinking about this patient. Other things that in terms of our assessment, looking at diuretics that we may be giving the patient and IV fluids. Does that make sense what we're doing? We want to be teaching about sodium administration and fluid restrictions, and we want to educate and avoid excessive sources of sodium, which includes medications that might include sodium. And of course, we want to have our patient rest so they can heal during this critical time. So I'm going to cover a couple electrolytes here. So hyponatremia. So hyponatremia, that is for a serum sodium less than 135 milliequivalents per liter. Hyponatremia can be acute, it can be chronic, and it can be exercise related. Causes of hyponatremia, it could be imbalance of water, it could be losses from vomiting, diarrhea, and sweating. It could be diuretics, it could be adrenal insufficiency, and it could be disease process syndrome of inadequate ADH hormone or medications. Things we might see on a hyponatremic patient: poor skin turgor, dry mucous membranes, headache, decreased salivation, hypotension, nausea, abdominal cramping, and neurological changes. An example of an acute hyponatremia would be possibly a patient flu overloaded due to a surgical case. Chronic, generally seen outside of the hospital setting. It could be chronic steroids, not drinking enough water. The chronic hyponatremia has less neurological consequences as the acute. And then exercise-associated hyponatremia. This is more common in women that are small in size. They may be exposed to extreme temperatures, such as when they're exercising, excessive fluid intake, and that would be exercise-associated hyponatremia. Biggest thing that we want to understand is our sodium's level less than 135. These patients are at risk for seizures, so we need to be paying attention to that. Medical management for hyponatremia. So for these patients, we want to treat the underlying condition. We want to thoughtfully replace sodium if we're giving it IV. It's either going to be NS, or if the patient is very hyponatremic, we might give them 3% NS, but that must be administered very slowly. If you administer 3% NS fast, the patient can develop cerebral edema. So that is not a good thing. Slow. We might want to put them on fluid restrictions. We might give medications such as sodium tablets. When we assess a patient, of course, we're going to be looking at level of consciousness, daily weight, their lab values, very important, and intake and output. Depending on the etiology, we may encourage dietary sodium intake. We're going to monitor their fluids, and we're going to monitor diuretics and lithium, things that can cause hyponatremia. Okay, hypernatremia. So this is when sodium is greater than 145 milliequivalents per liter. This can occur in patients with a normal fluid volume deficit or excess. It affects mostly the very old, the very young, or the cognitively impaired. In terms of remembering what are the causes of hypernatremia, we're going to focus on the model mnemonic. So it could be medications or meals, too much sodium, osmotic diuretics, diabetes insipidus, excessive water lossage, and low water intake. How we're going to treat it is we want to gradually lower the sodium via use of something hypertonic. We may give diuretics. We're going to assess for abnormal water losses and low water intake. Assess for over-the-counter sodium, because maybe they're taking something that has a lot of sodium, like certain dietary supplements have a lot of sodium. And we're going to monitor for central nervous system changes. Okay. Oops, went too far. Hypokalemia. So this is potassium levels below normal serum potassium levels, less than 3.5. Remember, each lab has their own range, their normal range. So for testing purposes, you are going to use the ranges in your textbook. So hypokalemia may occur when potassium, with normal potassium levels. It could be a patient that has alkalotic, like a DKA patient. Could be GI losses, new med suctioning, acid-base imbalances, hyperaldosteronism. What we might see are EKG rhythms, dysrhythmias, dilute urine, excessive thirst, fatigue, anorexia, decreased bowel motility, and paresthesias. The goal for this patient is to replace this potassium level safely. So we're going to give it either IV or PO. We're going to check the patient's urine output before we give any potassium, because if the patient's not putting out potassium, we clearly don't want to administer it. You're going to monitor the blood gases, monitor patients with DIG for toxicity, and look for signs and symptoms. Okay, so it's hypokalemia. Always, and I just wanted to say, as in addition to checking urine output, we're always going to run the potassium IV exactly how it's ordered. IV potassium can be very painful and irritate the vessels, so we might need to use ice to the site, or even sometimes cut the rate down. Hyperkalemia, that is serum potassium greater than 5.0. This rarely occurs in patients with normal renal function. It usually occurs in older adults. And hyperkalemia that is untreated can cause cardiac arrest. Causes are impaired renal function, rapid administration of potassium, hyperaldosteronism, tissue trauma, and acidosis. How are we going to treat it? So we're going to monitor EKG, assess labs, monitor intake and output. Always take an apical pulse. We're going to limit the dietary potassium, and we're going to teach to patients that have a history of hyperkalemia to try to avoid medications that are high in potassium. In some cases, we are going to administer a medication called K-Exalate. K-Exalate is a medication that induces a bowel movement. What happens is the potassium will bind to it and they'll excrete it in their stool. Emergently, we can give IV calcium gluconate, IV sodium bicarb, or regular insulin IV to help move the potassium from the interstitial to the intracellular space. And that's how we might treat. Those are different ways to treat hyperkalemia. All right, I'm going to stop here. Please let me know what questions you have.